Thank you again. The talk I'm going to deliver over the next 25-30 minutes is the current status of human hepatocyte transplantation. So those of you who work in the field of liver disease will agree that liver transplantation is the standard of care with good long-term patient and graft survival for anybody with end-stage liver disease, whether it's a chronic liver disease or acute liver failure. So if you have a very good outcomes of this treatment, then why don't we continue replacing people's liver? So what is the need for a new treatment? I would question that liver transplantation is not a cure, it's a disease. And it's a strange statement to make, particularly from somebody who is practicing liver transplantation as a clinician. The liver transplantation is a disease because once you have a liver transplant, you need to see your doctor for the rest of your life. You need to take medication to protect the liver against the immune system, and you need to put up with the side effects of the medication. So this qualifies all the characteristics of a disease, means it's a condition that you go and see a doctor, take the medication, require repeated blood tests. So if that's the case, then we can't call it a cure. And that means as the world goes forward, we need to innovate. Now, to innovate, we can look into the history and we look at first model of liver regeneration. This is a picture, you may have seen it already. I call it is a first human experiment or first model of liver regeneration, human model of regeneration, where what you find here is that Prometheus, who taught humans how to make fire, was convicted that he taught humans how to make fire. So he was punished, and mode of death was that his liver was exposed to the vulture here, and the story was that liver will this vulture will eat his liver every day and he will die. The story goes he didn't die because his liver kept regenerating. So if that is true, can we repeat this experiment in today's world? And if you have a scenario of a one-time insult to the liver, not a chronic liver disease, but an acute insult, whether it's a drug-induced liver injury or idiopathic acute liver failure, can you replace a part of the patient's liver with a donor liver, right or the left lobe? And in this cartoon, what you find is that patient's right or left lobe has been replaced. Here, patient's right lobe has been replaced with a donor graft. If you look at here, between first 2 weeks of transplantation, there is a very minimal activity in the patient's liver, while most of the activity is coming from the donor liver. What you find over time is, if you fast forward the film 1 year, we find that this patient has 2 functioning livers, but this is the patient's own liver ever recovered. Now, if this patient got a whole liver replacement, then this patient will have a disease for his life. Here, we have a 70% chance of him going off immunosuppression, and he did. As you can see, his liver histology improved from presentation to 1 year later. Similarly, if you look at metabolic disorders, single gene defect, liver, if provided with enough function of the missing enzyme, could change the phenotype of the disease as well. One example would be like if you have not a good quality tree in your garden, which is a mature tree but doesn't give you good fruits, you can prune the branch of that tree and replace that branch with another tree which has good quality fruits. In other words, this tree will have 2 types of fruits now. One not good quality, other is good quality. If you take the analogy in the liver disease in a metabolic disease patient, now this patient could have his own liver plus a donor left lobe, like a graft which you've taken from another tree. So this liver will have 2 types of enzyme production. So if you are doing it for Crigler-Najjar, urea cycle defect, this new donor liver will give you a missing enzyme, and this patient will behave like a heterozygous or not a phenotype of the disease that patient had. So for several liver-based metabolic disorders, this particular treatment, like auxiliary transplantation, and then we come to hepatocyte transplantation, could be theoretically attempted. To give you a flavor of the real life, this is an experience of ours for metabolic disorder of Crigler-Najjar syndrome, where auxiliary transplantation, if you see here, dropped the bilirubin level within the first 24 hours and it stayed down subsequently. Similarly, the long-term outcome of this patient we published in 2007, so that's what 13 years back. She was 10 years old, then now she's 23 years old, who had auxiliary transplant for propionic acidemia. And even 10 years later, if you see this patient has two livers, this is the donor liver, this is the native liver. And the reason we have done it, that if tomorrow there is a gene therapy available for this disease, this patient will have the benefit. If you did a whole liver replacement, then this patient will not have the benefit of having gene therapy. So with that background, that you don't need to replace whole of the liver to change in phenotype, could be transplant liver cells, or called hepatocyte transplantation. And the idea is that patients, the normal liver cells in an abnormal liver could repopulate the underlying liver. So before we do anything in humans, as you know, we have to prove these things, the proof of concept in animals. But this is a long list of animal models that has undergone hepatocyte transplantation and has shown a good outcomes in terms of gun rats being cured of his jaundice, and Dalmatian dog has been cured of hyperuricemia. In other words, all these animal models of human disease has shown a promise after treatment with hepatocyte transplantation. Similar in acute liver failure, whether caused by hepatectomy, vascular ligation, drugs, or toxin, in small and large animal models, both hepatocyte transplantation showed improvement. So what does it tell us? Where does it? These experiments that I showed you to set the stage is that when you can change the phenotype of the disease with auxiliary liver transplantation in metabolic liver disease, and bring the patient's liver back by regeneration in acute liver failure with auxiliary transplant, tells us that we don't need to replace the whole liver. We can get away with small amount of liver mass, and the question is how small that could be, and could that be gone down to the level of hepatocytes. After all, hepatocytes are the functional unit of a liver. So what we believe is that 5 to 10% of enzyme function is enough to change the phenotype. One example is like if you look at hemophilia, where you need 1 or 2% of enzyme function which change the phenotype of the patient and makes a huge difference to quality of life. The idea what we are promoting here is a repopulation of the liver. What we are trying to do here is that if the patient liver is not normal, cells are not normal, like an example is tyrosinemia, where cells are dying because of toxin succinylacetone. If you put normal liver cells, they have a selective advantage and they can repopulate the liver like in this cartoon. These cells will divide in the human, in the liver and replace the function. Our story goes back to 1990, and I'm showing this picture particularly for the gentleman in the middle, Ramsey Ragai Mitri. Ragai has been with us for the last 21 years now. Ragai has been a major driver behind our program. He is the head of liver cell production in our lab. And when I first started the program, I had Robin Hughes on the top right-hand side and Sharon and Ragai in the middle. And we carried on the program. Now the unit has grown up to about 12 people in the group. Robin has just retired, and I always in touch with Steve Strom, who's a friend and a mentor. The technique for people, just to give you an idea of what hepatocyte transplant involves, is the liver lobe that not used for transplantation is perfused with collagenase and is broken down by collagen digestion, and what it becomes is a mince like this one, and ultimately becomes a cell soup, like you can see in the beaker. You can put into these centrifuge tubes. We can put these cells in a bag and cryopreserve for future usage. Hepatocyte transplantation program or technique is not particularly complicated. The cells are transplanted in patients with metabolic disorders via the portal venous system into the liver. Portal venous system could be accessed by the transcutaneous puncture of the liver, or putting a catheter into the inferior or the superior mesenteric vein, accessing the portal vein. We put up to 1 billion cells per infusion. We match for ABO compatibility, and currently we use tacrolimus steroids as immunosuppression. This is a cartoon that shows that cells go into the liver. They should stay in the liver, but this is not working very well in this cartoon. Now, we have to understand the limitations. The journey of a liver cell is when they come into portal circulation, they're coming here, and the theory is that the cells will migrate between these pores into the space of this and reside and repopulate this particular hepatocyte plate. But if you have a cirrhosis or fibrosis, then these pores are blocked. There is a fibrosis in the middle, and the liver cells cannot go and home into the hepatocyte cords. So this technique cannot be used for children with cirrhosis. You can make the technique better. This is an example of using radiation injury to the liver, injury to the extent that it doesn't cause liver failure, but create a more space for liver cell to house. And that's an example of these cells, this in the animal model where the population of the liver is achieved after a radiation injury. So a group in Pittsburgh has used this technique in few patients, and they did radiation in phenylketonuria model and then transplanted cells and have shown some promise. The paper was published in Journal of Hepatology about 2 years back. The group in Karolinska used hepatectomy, and they are looking at transplanting cells into the rest of the graft and looking at when the graft, or the native liver, which has a injury, recovers, the same stimulus that grows the liver will grow the liver cells also. Where do we stand clinically? There are several reports, and there are in hundreds now. Everybody has done few cases and reported it. Majority of the conditions that has been addressed are metabolic defects, 54 in I last reviewed the literature, but there may be many others who are not reported in the literature. So I stand corrected if I'm not collected them all. Our experience goes with the examples with a few patients. This is a factor 7 deficiency disease, where if you look at after hepatocyte transplantation, we have done 3 patients. There are 2 in this paper. It shows that there is a reduction in the factor 7 requirement in these patients. Similarly, in Crigler-Najjar, we have shown a reduction in bilirubin from about 350 to 200, but also the reduction in phototherapy duration from 24 hours to about 12 hours a day. So that does make a quality of life, but nonetheless, these patients are not jaundice free. So mechanistically, if you look at, we are showing in the bile samples, we could demonstrate bilirubin glucuronides. That means these cells that were transplanted were able to conjugate bilirubin. And we're also able to show some low activity of bilirubin UPDP glucuronide transferase, the missing enzyme in Crigler-Najjar syndrome type 1. Subsequently, we have shown on short tandem repeat that the PCR evidence of the cells that were transplanted in the liver tissue. We also able to show that when the cells are transplanted in these livers, what we find is microthrombi of the distal portal venous system. I think that helps these cells to engraft because it causes endothelial damage, and that's what you need to get these cells across to the cell plate. I've summarized experience of 2 major metabolic conditions like urea cycle defect and Crigler-Najjar syndrome. Urea cycle defect, mainly OTC deficiency, that has been treated. But if you look on the right-hand side here, we all have showed, this is a group from Steve Strom from Pittsburgh. This is Mitri from Mass King's College. This is Horsland from Nebraska, Stefan from Belgium, Mayberg from Germany, and Ribes Canox from Spain. We all have shown that improvement in phenotype of none of us has cured anybody. The similar situation is with Crigler-Najjar syndrome. We all have shown a reduction in bilirubin, reduction in duration of phototherapy, but none of us has cured anybody. So the story so far with the metabolic liver disease and hepatocyte transplantation has been that it changes the phenotype, but up to about 2 years, nobody has cured anybody. Hence, there are work going on at the moment to improve the engraftment of these cells and longevity of the cells with various techniques. So at this point in time, if you ask me for liver-based metabolic disorders, hepatocyte transplantation is not curative, but it does give a phenotype change and some protection to particularly children with life-threatening conditions. Now, if you go back to the story of Prometheus that I showed you before, and is anything we can do differently for patients with acute liver failure? So just change, there are 2 different techniques we are talking now. I'm talking now of acute liver failure and cell transplantation. In acute liver failure, we need few things. We need a synthetic and detoxification function for few weeks because we expect the liver to regenerate. We will like to use this methodology or this treatment without any immunosuppression because these patients are already very sick. If you immunosuppress them further, they have a high risk of sepsis and infections. And also, if you were to perform a procedure, then we would like a patient who's not coagulopathic, coagulopathic. So we need to access their venous system with coagulopathy. That could be dangerous. So we need to access a place which is easy to access. So in 2005, we come up with this idea that can we put these cells into the beads? And Ragai Mitri developed this program in my group further, putting these cells through this encapsulator. And what it does is the cells, as we isolate further, goes into this machine, and then the cells go into this salmon-like egg-like structures, and each bead has got several hundred cells in it. Before we go to patients, we have to do lots of experiments to prove that the cells in these beads are functional. So this is mitochondrial function, this is urea synthesis, this is factor 7 productions, meaning that synthetic and detoxification function of the cells has been retained. Then we culture these cells in the ascitic fluid, where the patient's ascitic fluid is the place where the liver cells will go in the peritoneal cavity. And we do show that these cells are functional in 50% concentration. If you look at 3D confocal microscopy of these cells beads, they show that the cells in the middle, the red ones are the dead ones, the green ones are the live ones, and they're equally distributed around. So means these cells in the beads are equally distributed, and most of them are alive. We took this treatment first to humans, experienced under medical specialist license. And the idea was that these cells will not be affected by the immune system, and the toxins like ammonia will go in and urea will come out, which we had proven before in our laboratory experiments. Technically, the treatment delivery is very simple. You can, with an ultrasound catheter guided, you can put a catheter in the peritoneal cavity, which most of you will say it's a very simple technique. And these are the cells, the beads, they look like from great vision under the microscope. The initial experience published in Journal of Hepatology last March showed that 8 of our patients who were listed for transplantation and fulfilled the criteria and a predicted 90% mortality, 4 out of 8 were able to survive without transplantation, telling us that either this treatment works or we were over-transplanting these patients. So, ladies and gentlemen, story so far has been for metabolic disorder that we have an evidence of function change of phenotype for up to 2 years, while in acute liver failure, we have about 50% native liver survival against 90% predicted mortality. So if that is so good, then why is this technology is not gone further? What are the bottlenecks? So I would like to address how we have addressed some of the bottlenecks to the success of this therapy. So this is a list of few things. And what we were able to do is use 1 liver for 3 patients. And that's an example of maximizing the donor pool, taking liver cells from the non-heart beating donors, fetal liver cells, marginal donors, and then stem cells. This is an example of 1 liver being used for 3 patients, mean the caudate lobe and the segment 4, which is a small, about 100 grams, and can be used to isolate cells and transplant into a patient, which was the case here. One of these babies received this transplant from the caudate and segment 4. We have developed a program of isolating cells from the neonatal livers, which has been very successful. But we have to demonstrate that these cells are functional, for metabolically active, and they are not premature like premature babies. That's not the case. Hence, these cells are good for human transplantation. We have taken that technique further, and we believe that we can reduce the number of hepatocytes that are required by improving their quality by co-culturing these cells with mesenchymal stromal cells. Mesenchymal stromal cells have a unique capability to act as immunomodulatory, anti-inflammatory, in tissue regeneration, and decreasing oxidative stress. Putting all these together with hepatocytes, what it does is it improves viability, functionality, and attachment. These experiments we proved about 7-8 years back. We showed when the hepatocytes were co-cultured with with mesenchymal stromal cells, these cells had a improved production of albumin and urea synthesis. We were interested in mechanistic side of it, and we were looking at how we can prove what the mechanism of action is. Amongst many approaches, we looked at whether there is a nanotube formation between the mesenchymal stromal cells and hepatocytes, and very preliminary evidence shows that there is a transfer of mitochondria-like material in these nanotubes between mesenchymal stromal cells and hepatocytes. Our next project at the moment is, which is just got approval from the MHRA, to co-culture cells and use them to transplant them in patients with acute liver failure using a novel allogeneic which has an intellectual property life pending at the moment. What I've showed you so far is relies on the human, the whole program sets up on the cells from the human liver donated. But as you know, human livers are increasingly used, whatever condition they are. Hence, this program is not viable until and unless we get cells delivered to us from stem cells. The stem cell source is either induced pluripotent stem cells or embryonic stem cells are the good source, but at this point in time, we do not have a GMP, FDA, MHRA approved cell line that we can use for clinical usage. Till such time that happens, we have to rely on the human mature liver cells source. But one day, I think when we have the bucket full of cells coming from the embryonic or induced pluripotent stem cells, I think the technique, our field will get a further boost. To conclude or reflect, ladies and gentlemen, I think history of medicine is such that what was inconceivable yesterday becomes a routine tomorrow. Hence, my request to you is regenerate and not replace. And I take a lot of comfort from this gentleman, Donald Thomas, who was Nobel laureate in 1990, and he brought bone marrow transplantation to us. And nowadays, when you talk about bone marrow transplantation, most of us will not blink an eyelid. It's a standard procedure with very good outcomes. But can you imagine if you were to develop bone marrow transplantation in the era of new CAR T cells? So our problem with the hepatocyte transplantation is we are competing with a very successful treatment, which is liver transplant. Hence, the progress in the field of human hepatocyte transplantation is very slow. If we did not have human liver transplantation, then maybe people only have this option, and many more centers will be doing it and would have been a success by now. So I'm hopeful that we persevere, colleagues in few other centers that are doing it, and one day we will be regenerating livers and not replacing. I think this is my lab group. Ragai Mitri, I showed you the picture, and the rest of the group follows there. My liver surgical colleagues, radiology, and these are the organizations that give us grant money to keep this program going. I thank you for listening to me, and I will take questions in the live session.
Good afternoon, ladies and gentlemen. This is my second talk for the day, and I'm going to talk about the mechanism, outcome, and prevention of perinatal infections. So perinatal infections, as you all know, these are important cause of stillbirth and morbidity, and most of these infections goes undiagnosed. These group of infections, they were given acronyms by Andres Neemaas in 1971, the Toxoplasma, Rubella, CMV, and herpes simplex. And in 1975, Harold added the syphilis to the acronym. These acronym now in the recent era, they are, because of addition of new diseases, now they are called as TORCHES, or the new addition of disease CLAP, which involve the chickenpox, Lyme disease, AIDS, and parvovirus B19. The perinatal period, particularly, I like to say that it is described a time period between 22 weeks to 30 days after birth. So most of the infection we call as vertical transmission of pathogens from mother to fetus can occur in 3 time period, during, we call them congenital, in vitro transmission through placenta. Perinatal transmission occur during labor and delivery due to exposure to anogenital secretions and hematogenous. And whereas neonatal, the infection which are contracted after birth due to direct contact or of the secretion or breast milk, or they could be nosocomial. Now, mechanism of perinatal infection is mainly how they cross through the placenta. As you all know, placenta is a physical and immunological defense against fetal infection by immune cells in the placenta and antimicrobial peptides. When this placental barrier fails, the pathogen breach the innate material immune system and placental host defense to infect the fetus. So these are the general clinical features the newborn or fetus can present once they contract the perinatal infection in the form of intrauterine growth restriction, non-immune hydrops, anemia, leukopenia, thrombocytopenia, and different organ involvement. And congenital malformation presentation, it varies what time the infection and has occurred with particular pathogens. Now, I will describe in the next few slides the bacterial, viral, and parasitic perinatal infections. This slide just shows the most of the bacterial perinatal infection. The first three, which are highlighted in yellow, they are the most of these infections are transmitted intrauterine, and some of the infection like group B, which is can be transmitted by through the genital secretions as well, or an hematogenous. The group of syndrome they can cause is predominantly meningitis or neonatal sepsis, pneumonia, or they can be present as a localized infection. And listeria, most of you know, it can be intrauterine or perinatal period. The most important syndrome caused by listeria is meningitis. Now, these two, Neisseria and chlamydia, trachomatis, they are sexually transmitted diseases and mostly infected during the intrauterine or through the perinatal from the genital secretions. And the most important syndrome caused after the birth is ophthalmia neonatorum and pneumonia and sepsis. Now, I will describe a little bit in more detail the syphilis, which is caused by Treponema pallidum, and predominantly it is transmitted during transplacental transmission and hematogenous. So the syphilis can be presented in the three phases. It can present at birth in the form of, it can be stillbirth or low birth weight babies. They can present with simply hepatosplenomegaly, hydrops, hemolytic anemia, and neutropenia or thrombocytopenia. Whereas a late neonatal onset is after 5 weeks, and their presentation can be very wide in the form of there can be the bone formation problem and maculopapular rash, syphilitic rhinitis, and it's important to see the CSF at that point to see pleocytosis or high protein. So congenital syphilis is the most common syndrome what we see, and presentation is usually after 2 years after birth. We all probably know Hutchinson triad in the form, present in the form of interstitial keratitis, eighth of damage, and Hutchinson teeth. And the other most important presentation of congenital syphilis is Clutton joints. That means there is paleness swelling of the joint. Mainly, it is important to diagnose both mother and newborn, and mothers should have the screening test during their pregnancy, and that can be done by serological test. If the screening test of IgG are positive, they are further tested by VDRL and RPR, and specific test, triple antibody test, is done by hemagglutination test. So newborn, if positive, should always consider CSF serology, that should be performed so as to rule out the neurosyphilis. And treatment usually is very simple, and that is we give penicillin G for 2 weeks. And in case of diagnosis of neurosyphilis, a CSF antibody titers should be monitored every 6 months up to 3 years. Now, this is the list of viral and parasitic perinatal infection. I will describe them briefly, and have added 2 more viruses, emerging new viruses, Zika virus, and brief discussion about the COVID-19. So congenital cytomegalovirus infection, this is the most commonest perinatal viral infection, and it is transmitted to fetus during all stages of pregnancy. If the mother has primary CMV infection, that has chances of 32% placenta transmission to fetus, and 5 to 10% symptom fetus can be symptomatic at birth, and 10% may develop sequelae post neonate with the sensory neural deafness and learning difficulties. And some of the severe infection can have stillbirth. So 90% asymptomatic, 10% may develop sensory neuro hearing loss and chorioretinitis. Later in childhood, they can have disorder of psychomotor development. So this is that kind of study here, which I'm showing is from all the 3 big countries, Australia, England, and United States. And they have shown a congenital CMV infection of 0.6%, which is quite low. But you see that the disability in symptomatic birth have developed up to 50% has developed the disability, whereas asymptomatic at birth has developed the disability are quite high, which is 13.5%. So congenital CMV infection is caused by damage to the fetus from destruction of target cells once they are formed, and clinical manifestation could be very variable, starting from anemia, leukopenia, thrombocytopenia, a microcephaly, and the most important is the sensory neural deafness. Hepatitis we have seen quite often in our center, pneumonitis, and some really could be hepatosplenomegaly. So it is important how we diagnose in neonates is through the IgM, or DNA is nowadays is the most important way of diagnosing. We can diagnose that in blood, urine, saliva, or if it's the tissue sample, then CMV inclusion bodies could help in the diagnosis. Now, the treatment of congenital CMV is controversial, but it has been consensus guidelines suggest that we should treat them with valganciclovir for 6 months for congenitally infected neonates who has moderately to severe symptomatic disease. However, treatment is not recommended for asymptomatic patients. So this is the consensus guideline, which was done in US in 2014. And if you'd like to read, they have clarified how congenital CMV should be treated and which group should be monitored during treatment. So what is the prevention? Can we prevent that? There is no consensus guideline or validity of antenatal newborn screening, or role of antivirals is not known during pregnancy. However, in the future, we may some vaccination may become available in the near future. So second group I'd just like to discuss is neonatal herpes simplex virus, which is another common type of perinatal infection we see in the neonates. The spectrum of neonatal HSV infection, it varies from mild localized infection to a disseminated disease. And disseminated can affect liver, adrenals, and brain. Most of them can present with acute liver failure, encephalitis, and pneumonitis. And particularly, infection is dangerous in premature infants. They can easily, if you recognize that these patients should be easily treated with acyclovir high dose. And in terms of prevention, If the mother has florigenital lesion, cesarean section should be considered. Other virus is congenital parvovirus infection. As you all know, this is the causative agent of fifth disease, clinically difficult to distinguish from the rubella. It can spread by respiratory route, and so most of the population is eventually infected and immune. However, still 50% of women of childbearing age are susceptible to infection. Presentation of congenital parvovirus, it can cause fetal loss through hydrophytalis and anemia. It can cause congestive heart failure, generalized edema, and fetal death. So risk of fetal death is highest during the second trimester of pregnancy, which can be up to 12%. And how we can prevent it? If we diagnose it hydrophytalis, termination is not required. However, that can be successfully treated in vitro by intrauterine transfusion and administration of digoxin to the fetus. Now, another most important syndrome is congenital rubella. It is rare because most of the women, they receive the vaccines and are immune. So the women who are not immune, they can contract the rubella during pregnancy and cause the most important syndrome, which is called as congenital rubella syndrome. Highest risk is during the first 12 weeks, and classical triad of CRS is cataract, heart defects, and sensory neural deafness. And other abnormalities could be meningoencephalitis, hepatitis, hemolytic anemia, and lymphadenopathy. Now, to prevent the CRS, it is considered to consider termination of pregnancy, and antenatal screening is very important. Most of the centers or women are screened for the rubella immune status, and non-immune women should be considered for vaccination because it's live vaccine, so they should be considered in the immediate postpartum period. So varicella zoster, a virus which also known to cause a chickenpox. Although the chickenpox is quite highly prevalent in the community and most of the pregnant women will be immune. However, some of the women who are not immune, they can contract a primary infection during pregnancy, and the primary infection can be very severe. If the contract in the first 20 weeks of pregnancy, there are 3% chance of transmission to the fetus, which can cause congenital varicella syndrome, which manifests in the form of scarring of skin, CNS and eye defects, and infant mortality. Now, late stages of pregnancy, varicella can cross the placenta and cause mild disease to fetal disseminated disease in a fetus. So during pregnancy, it can be treated if we recognize it early, and treatment is acyclovir. However, there is a prevention, varicella specific immunoglobulins are available, which can be given both for mother and infants. And the specific time period is ideally we should be giving them 7 days before the delivery. So Toxoplasma is one of the parasite which is the most commonly described to cause the perinatal infection. It affects 0.3 to 1% of pregnant women, with 30 to 50% transmission to risk to the fetus, and risk of infection increases with gestation age. Highest is in the third trimester, which we can see up to 65% fetus can contract the Toxoplasma. And 90% newborns are without clinical infection, and we should be able to detect the transmission to fetus either by looking for anomalies by ultrasound, or can consider amniocentesis. And how we can detect is in the fetus and mother, we can look for IgG seroconversion or presence of IgM in fetus. And nowadays we can do toxo DNA PCR in various specimens in CSF, in the blood, to detect the toxoplasma DNA. At treatment, it is usually self-limiting limited disease in patient. However, mother, if we diagnose early, they should be treated with pyramycin until term. Hepatitis B virus is one of the another virus which can be transmitted in late pregnancy, and transmission is at highest when there is a high HBV DNA and HBs antigen and HB antigen positive. However, it should not be considered contraindication for breastfeeding, and hepatitis B vaccine should be given to most of the pregnant women. It provides the 90% active immunity, and there are hepatitis B immunoglobulin which can provide additional 5 to 10% immunity, and 90% of infected infants can become chronic carrier. So there's something I like to describe about Zika virus, which is one of the emerging perinatal infections. It is one of the flavivirus and found mainly in tropical areas of Asia, Africa, and in US. It is transmitted by one of the Aedes mosquito and can also be transmitted sexually or by a blood transfusion. And most infections are asymptomatic. And Zika virus, it was first reported to be associated with microcephaly and GBS by Brazil in 2015. The risk of an infected pregnant woman is 4 to 5% who are at risk of congenital abnormalities, and including microcephaly. This is based on the US data. However, in the 2018, this report from CDC, which has shown that 1 in 7 evaluated children had a Zika virus associated birth defect, a neurodevelopmental abnormality, and possibly associated with congenital Zika virus infection. An infected pregnant woman should be followed up routinely by ultrasound, early referral to intervention services. Now, there's something, the last one, ongoing problem of COVID-19. What is the evidence of emerging perinatal infection? There is no definitive proof of transplacental transmission of the COVID-19. However, there has been a study which has proved that neonatal COVID-19 was reported. And this is the 14 studies of COVID-19 pregnancy reviewed. They suggest a lack of consensus or diagnostic strategy for congenital infection. If you see, they have tested the COVID-19 in various specimens, including vaginal secretion was positive in 22% of cases, amniotic fluid 35%, in breast milk 22%, and they have found positive in umbilical cord blood. However, when they have done the histological examination of the placental tissue, they have found the sparse viral particles and vascular malperfusion and inflammation. However, still there is a lack of placental COVID-19 receptors expression, which may explain why the placental infection is not associated with COVID-19. So in conclusion, I will like to say that to avoid all this perinatal infection, it is important that we should have a detailed maternal history, which we can ask various questions to exclude the various types of perinatal infection. Some of them which we routinely should ask: exposure to undercooked or raw meat or soil or animals, history of sexually transmitted diseases for mother and partner, risk factors for HIV exposure, illness during pregnancy, if they have any history of fever, rashes, exposure during pregnancy to ill children, say daycare in the teacher, and maternal serology, and if they are obtained. Another important way to prevent these are the systematic screening. For some infection, routine screening play a major role, and in early diagnosis and timely treatment can prevent all the perinatal associated infection associated complications. Preconceptional and antenatal screening of mother is important. Like in our center or in UK, we do routinely group B screening, rubella and rubella, syphilis as a part of antenatal screening. And neonatal screening of the infant is important, and it is important to have the education of the mother. The other way to prevent is most important way is immunization. Maternal immunity can be transmitted passively to fetus and could prevent from various infectious complications. And vaccines should be administered in the preconceptional period. And thank you for your patience, and stay safe.